Whether you're studying to be a physician assistant, or nurse practitioner, we feel like this pharmacology course is the right course for you. So I hope you enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome.
Hello, I'm Dr. Michael McInnes. I'm an internist, and this lecture is Pharmacokinetics Part 2. So in the Part 1 lecture, we talked about the four main pathways involved in pharmacokinetics, which are absorption, distribution, metabolism, and elimination. And we covered the first couple of those. We covered absorption and distribution. In this lecture, we're going to cover metabolism and elimination. Now, this is a lecture that is heavy on vocabulary and new terms and new concepts. It's also heavy on some math and some equations. And we're going to cover which of these equations are really important for you to memorize, and which ones you just sort of need to be familiar with and sort of understand without really memorizing. So we'll touch on that as we go along. So when we talk about drug metabolism, drugs are metabolized by a process we call biotransformation, meaning they're transformed from one molecule to a slightly different molecule, a slightly altered molecule. And this often happens in the liver and sometimes in the kidneys and other tissues. And they can be excreted, meaning they're removed from the body in the bile, and that goes into the feces, or they can be excreted in the urine. The liver is the major site of metabolism and biotransformation, but as I said, other sites, the kidneys, the intestines can be involved, and then the major site of elimination is the kidneys, which we'll talk about second. Some drugs are what we call prodrugs, which means those drugs have to be metabolized into an active product in order to be biologically active. An example of this is heroin, or the chemical name is diacetylmorphine. And heroin is a prodrug that is converted into morphine. Diacetylmorphine by itself is not terribly strong, but then it's converted into morphine. We're going to talk a lot about the kinetics of metabolism. And this is where we get into some of the math, and I don't want you to panic about this stuff. These kinetic formulas, these kinetic equations are important for drug metabolism, and they're important for enzyme kinetics, and they're important for receptor kinetics. And we'll talk about enzyme kinetics and receptors in lecture number 3, which is pharmacodynamics, when we're talking about competitive inhibitors and non-competitive inhibitors. But this topic is also very high yield for your board exams like USMLE Step 1 and for the COMLEX Level 1 exam. One student told us that you need to know Km and Vmax like the back of your hand. So we're going to talk about Km and Vmax, even though those aren't really strongly covered in Lippincott. This stuff is not hard. It's a little unfamiliar, it's a little confusing at first, but it's really not hard. You just need to kind of solidify the concept in your mind. Try to comprehend it, try to understand it. Don't just memorize it and move on. Try and get it to stick in your brain, and then kind of keep reviewing it and reminding yourself about it so it stays stuck. So we're going to talk about Vmax. When we look at this image, we see a graph of Michaelis-Menten kinetics, this is a graph similar to the one in figure 1.14. So along the y-axis, you have the rate of drug metabolism, or it's the rate of an enzymatic reaction, if that's what you're talking about, because most drugs are metabolized by enzymes. So this is an enzymatic reaction as well as drug metabolism. And here on the x-axis, we also have the dose of the drug, or the concentration of the substrate. So the x-axis is a concentration or an amount, and the y-axis is a rate or velocity or a speed. And you'll notice from this graph that at low concentration and low doses, the rate of the reaction, which is y, it gets faster and faster and faster as the concentration x increases. So as the concentration on the x-axis increases, that slope curves upward very steeply. And during this phase, it's what we call first-order kinetics. And we're going to come back to that and explain what that means in a moment. But you see over there on the far right part of the graph, at the higher concentration, the rate plateaus. And no matter how much substrate you give, no matter how much drug there is, the rate, which is that value of the y-axis, the rate is not changing. And we call this portion of the graph zero-order kinetics. And we'll come back to that in a moment as well. So imagine that you have an enzyme and all of the reactive sites are occupied. That means the reaction or the metabolism involved has reached its maximum velocity. That's Vmax. V for velocity is at its maximum. So Vmax is a rate, it's a velocity, it's a speed. If you want to increase Vmax, How can you do it? Well, you can increase the amount of enzyme, because if there's more enzyme, you have more active sites to catalyze the reaction. So Vmax is proportional to the enzyme concentration. So arbitrarily, if you look at the graph, we mark 1/2 of Vmax. So if Vmax is a velocity or a rate or a speed, if your car has a maximum velocity of 90 miles an hour, then the half Vmax of your car is 45 miles an hour. And that's really not very difficult. So that's half Vmax, is half of that maximum velocity of the reaction. The next concept we're going to talk about, which you can also see in the graph, is Km. Now Km is called the Michaelis constant. And Km reflects the substrate or drug concentrations. Km is the concentration at 1/2 Vmax. So Km reflects the affinity of the enzyme for the substrate. If you have an enzyme that has a very high affinity for the substrate, it's going to take less substrate to achieve that half max velocity. A lower concentration, you get a lower Km. If you have an enzyme that has a lower affinity for the substrate, on the other hand, it takes more substrate to get the reaction up to the half max velocity, or 1/2 Vmax. So if you have a higher concentration, you have a higher Km. So if you can remember, if you can keep in your mind that Km is a concentration of substrate, you can kind of reason through this process. If Km is higher, that means it takes a higher concentration. Remember, Km is a concentration, so it takes a higher concentration of the substrate to get the velocity to 1/2 Vmax. And that means that the enzyme has a relatively low affinity for the substrate. So now that you understand all that, we can go back to Lippincott on page 13, and we're going to talk about first-order kinetics. So this first equation that they give you is not one of the four equations that you need to know for your board exams. So there are 4 equations that you need to know for USMLE Step 1 or for the COMLEX Level 1. This is not one of those 4 equations. And you'll see it's V equals Vmax times C, or the concentration, divided by Km plus C. So we already know what Vmax is, and we already know what Km is. Concentration C is the concentration of the drug. What's the concentration of the drug in the plasma? How much drug is there? We're talking about enzymatic metabolism of drugs, so the drug is our substrate, S. So you might see it represented as S for substrate. You might see it represented as C, as it is in Lippincott, for concentration. So in most situations, the concentration of the drug is much, much less than Km. So the denominator of our equation there is basically just Km. The C that you're adding to it just cancels out because it's insignificant. So you do a little algebra and you get V equals Vmax times C over Km. Or you rearrange that and you have V equals Vmax times C over Km. So what that means is that you have a constant fraction of the drug represented by C divided by Km. So some fraction of the drug is being metabolized per unit of time. And this is first order kinetics. So what does this mean? In first order kinetics, you have a constant fraction of the drug metabolized per unit of time. So it might be 10%, it might be 25%, it might be 14.2%, but it's some percentage, some fraction that's going to be metabolized. So the absolute amount that you're metabolizing, the number of milligrams you're metabolizing, depends on the concentration you're starting with. So imagine for a minute you start with 100 milligrams of drug in the blood. And you're going to metabolize 10% of that per hour. So after the first hour, 10% of that 100 milligrams is 10 milligrams. And so after that first hour, 90 milligrams is left. Now after the second hour, you're metabolizing 10% of 90 milligrams. So that's only 9 milligrams. So 90 minus 9 is 81. And that's what's left after the second hour, is 81 milligrams. And after 3 hours, you're going to metabolize another 8.1 milligrams, another 10% of that 81, and you're going to be left with 72.9 milligrams. And after 4 hours, you're going to metabolize a little bit less, and after 5 hours, you're going to metabolize a little bit left. So remember our Michaelis-Menten graph. At first, the available enzyme is not saturated, so adding more substrate increases the velocity of the reaction, right? That's first-order kinetics. The rate of the reaction is dependent on how concentrated the substrate is. So next we're going to talk about zero-order kinetics. And again, remember this same graph, this Michaelis-Menten graph. At some point, you're going to saturate the enzyme sites and reach your Vmax on that far right-hand side of the graph. No matter how much substrate you give, you're still limited, and the amount of drug metabolized in a given time doesn't change. So remember in our first order example, you metabolized 10% of the drug each hour. That meant in each subsequent hour, we're metabolizing a smaller amount. We're metabolizing fewer milligrams each hour. With zero-order kinetics, though, you're going to metabolize a constant amount, not a constant fraction. So instead of metabolizing 10% per hour, we might metabolize 10 milligrams an hour. So you start out with 100 milligrams in the body, and after the first hour you metabolize 10 milligrams of that because it's a zero-order kinetics, and you're left with 90 milligrams. Well, that's the same for first order and zero order. But in the second hour, what are we metabolizing? Well, we're metabolizing a constant amount. We're going to metabolize 10 milligrams of that, so we go from 90 to 80. And in the third hour, we're going to metabolize another 10 milligrams, so we're going from 80 to 70, and so on. So you can see there's a subtle difference in how these drugs are metabolized. And the curve of zero-order kinetics is more linear, whereas the curve of first-order kinetics is an exponential curve. It's a rounded curve. So there are three notable drugs, three high-yield drugs that are metabolized using zero-order kinetics for you to know. The three drugs are phenytoin, ethanol, and aspirin. Phenytoin is a drug used for seizures. Ethanol is alcohol. You all know what that is. And aspirin, of course. So the mnemonic for this is PEA. And you can remember it that a P is round. It's like a zero. So that's zero-order kinetics. So the three drugs that are notably metabolized using zero-order kinetics are phenytoin, ethanol, and aspirin. So with these drugs, with these zero-order drugs, the concentration of drug, which is C, is much higher than Km. So the denominator cancels out, and you're left with V equals Vmax times C divided by C, or V equals Vmax. So again, just like we saw on our Michaelis-Menten graph, on that far right-hand side, the velocity of the reaction is maximized at all times. It's independent of the concentration of substrate. The velocity is going to be Vmax no matter what the concentration of the substrate is. So for the moment, that's all the math and formulas we have to deal with. We'll come back to some more math in a few moments. So let's talk about the different types of reactions involved in drug metabolism. Most drugs are eliminated from the body in the urine, but lipophilic drugs, hydrophobic drugs, are filtered into the urine, but then they're going to keep diffusing out through the cell membranes and go back into the interstitium and be reabsorbed into the systemic circulation. And that happens in the distal tubules of the kidneys, which we'll see in a moment. So the body needs to figure out a way to make those hydrophilic drugs hydrophobic so they'll stay trapped in the urine and they can be excreted. And this is where we come into our metabolic reactions. We talk about phase 1 and phase 2 metabolism, and you need to know the difference between the two. Both of these phases generally take place in the liver, but they're not necessarily sequential. It's not like a drug has to go through phase 1 before it can go through phase 2. A drug might take one pass through the liver and go through a phase 2 reaction, and then it might pass through again and go through a phase 1 reaction, and it might pass through again and go through another phase 2 reaction or something like that. So they're not necessarily sequential reactions. So in phase 1, these reactions are oxidation, reduction, and hydrolysis reactions. Generally, the result is the drug that's slightly more polar than it was before the reaction, and you can either increase or decrease the pharmacological activity of the drug with a phase 1 reaction, or it can be unchanged. So you may hydrolyze the drug and not change its pharmacologic activity at all. So there's no guarantee with a phase 1 reaction. The most important enzymes involved in phase 1 reactions are the cytochrome P450 enzymes, and we're going to talk about those extensively in just a moment. But there are other enzymes involved that are not P450 enzymes, enzymes involved in amine oxidation, alcohol dehydrogenation, hydrolysis, and esterases. And it's important to note that elderly patients generally lose their ability to perform these phase 1 reactions first. So if you're asked on a board exam question, you've got an elderly patient who is no longer able to metabolize this drug. Is this most likely a loss of phase 1 or phase 2? The answer is phase 1. In phase 2 reactions, we're talking about conjugation of the initial drug with some other acid, usually glucuronic acid or sulfuric acid or acetic acid or an amino acid. And this results in a more polar drug, a very strongly polar drug that's water soluble, and it can be concentrated in the urine or it can be concentrated in the bile, and then it can be eliminated. Usually a phase 2 reaction is going to inactivate the drug. So a phase 1 reaction may or may not inactivate a drug, but a phase 2 reaction usually will. And the most common and most important phase 2 reaction is glucuronidation, conjugation of the original drug with glucuronic acid. So let's talk about the cytochrome P450 system. This is a family of enzymes, and again, these are phase 1 metabolizers. So these P450 reactions are phase 1 metabolism. In this family of enzymes, these enzymes are found in lots and lots of tissues, but they're especially common in the liver and in the GI tract. So we need to talk a little bit about how we name these things. Cytochrome P450 designates the entire superfamily of enzymes, and it's sometimes abbreviated CYP. And then the individual drug is designated with a number and a letter and a number, which stands for the family and the subfamily and then the specific isoenzyme. So for instance, we might talk about CYP3A4, which is the cytochrome P450 enzyme in family number 3, subfamily A, and the specific isoenzyme 4. So there are 6 isoenzymes that are the most important ones for metabolizing most drugs. And you'll see them on the screen there: 3A4, 2D6, 2C9 and 10, 2C19, 2E1, and 1A2. The most important of these, the most common one of these is CYP3A4, which metabolizes about 60% of drugs that are currently on the market. Now, an individual drug can often be metabolized by more than one P450 enzyme. So you'll see in Lippincott's, CYP3A4 metabolizes about 60% of drugs, and 2D6 metabolizes about 25% of drugs, and so forth. And you add all those up, it adds up to way more than 100, because certain drugs can be metabolized by more than one enzyme. The enzymes generally exhibit some genetic variability, which is why there are differences in therapeutic responsiveness and risk of adverse events and dosing differences. You give one drug to 10 different people and they might have a different response to the drug or different toxicity because certain people are going to metabolize these drugs faster or slower than other people. CYP2D6 shows genetic polymorphism, so there are a lot of different genetic variables in this specific enzyme. And this is partly racially determined, and you'll see that in Lippincott's as well. I won't go through that. Some drugs induce the synthesis of certain P450 enzymes. They list 3 of these in Lippincott. They list phenobarbital, rifampin, and carbamazepine. Now, you can't possibly learn all the drugs that induce the cytochrome P450 system. There are too many drugs and too many enzymes involved. But I'm going to give you a mnemonic that's going to give you 7 of the big ones, 7 of the ones that you're going to want to remember. The mnemonic is BCG-PQRS. BCG is kind of a vaccine against TB, so you'll hear about that more later. BCG, that's something, it's a medical term that you may not have heard so far. So this mnemonic stands for barbiturates, which includes phenobarbital, as we mentioned. C is for carbamazepine, which is an anti-epileptic drug. G is for griseofulvin, which is an antifungal drug. P is for phenytoin, which again is an anti-seizure drug. Q is for quinidine, which is an antiarrhythmic drug. R is for rifampin, which is an antibiotic often used for tuberculosis. And S is for St. John's wort, which is an herb used to treat depression. Now, look back at this list for a minute. We've already seen phenytoin once in this lecture when we were talking about drug metabolism. What did we say about phenytoin? You remember? Remember, phenytoin was one of those 3 drugs that demonstrate zero-order metabolism. And do you remember what the other 2 were? The mnemonic was PEA, so phenytoin, ethanol, and aspirin. You remember that a P is round like a 0. Now, you notice also that quinidine is on that list of P450 inducers. Quinidine can induce some enzymes. It can also inhibit other P450 enzymes, but overall, induction of P450 system is much more important. So that's why we listed in this mnemonic. So if a drug induces the P450 system, there's more of the specific P450 enzyme available, and so you're going to metabolize its substrates more rapidly. And what this means is you may alter the therapeutic effectiveness of drugs. You may make a drug less effective or more effective if it's a reaction that is making a drug more effective. So there are four basic ways when that you're altering the therapeutic effectiveness. You're going to potentially decrease plasma concentrations. You might decrease drug activity if the metabolite is inactive. You might increase drug activity if the metabolite is active. And you might decrease the therapeutic drug effect. So some drugs can induce the P450 enzymes. Other drugs can inhibit the P450 enzymes. They actually compete for the binding sites of the enzyme. And sometimes these drugs are inhibiting the P450 enzyme for which they're not the substrate. So it may be metabolized by one enzyme and it's actually inhibiting another enzyme. And Lippincotts lists three of these drugs that inhibit P450. It lists erythromycin, ketoconazole, and ritonavir. Each of these inhibits several P450 enzymes. I'm going to give you a different mnemonic to remember a long list of drugs that inhibit P450. And again, you can't memorize all of these, but these are some important ones. The mnemonic is pick eggs. P is for protease inhibitors, which are drugs used for HIV, and ritonavir is a protease inhibitor. I is for isoniazid, which is another antibiotic used for tuberculosis. C is for cimetidine, which is an H2 blocker, a histamine blocker that's used to suppress gastric acid. K is for ketoconazole, which is an antifungal drug. E is for erythromycin, which is an antibiotic. G is for grapefruit juice. And S is for sulfonamides, or sulfa drugs. These include antibiotics, sulfonylureas, which are used to treat diabetes, and thiazide diuretics. So you'll notice on there one thing that's not a drug, which is grapefruit juice. Grapefruit juice inhibits cytochrome P450 3A4, which, remember, metabolizes about 60% of drugs that are out there. So that's a pretty important interaction. Plus, it's one that is not going to show up on a patient's drug list. You might look at a patient's drug list and say, oh, they're on this drug which is going to inhibit or induce P450. But you're not going to see grapefruit juice. So you need to kind of be in the habit of asking patients if they drink grapefruit juice or if there's a problem with how well a drug is working. You might find out that they're drinking grapefruit juice, and that may be inhibiting their P450 metabolism. So inhibition of the P450 enzymes can lead to higher blood levels of the drug. It can lead to prolonged duration of the action of the drug, and sometimes it can lead to increased toxicity of the drug.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
Hello, Dr. Einstein here again. Feel like you're absorbing all the information? We shall see about that. Tell me this, is conjugation a phase 1 or phase 2 reaction? Need some time, do we? Very good. The answer is phase 2. Conjugation usually leaves the drug inactive. If you thought that was too easy, then here's a real doozy for you. Which takes place first, phase 1 metabolism or phase 2? Trick question. The reactions can take place in any order. You just got Stein, son.
Let's go through the answers to quick review number one. Number one, label the following graph of Michaelis-Menten kinetics. So this graph is very important to understand and be able to label. So A on this graph is your Vmax, your maximum velocity. B is 1/2 of Vmax, which gives you C, your Km, the concentration of substrate that's required to reach 1/2 of Vmax. It's Km. D is showing an area of the curve where there is first order velocity. So the velocity of the elimination and metabolism is directly proportional to the concentration of substrate. And then E is showing zero order velocity, where it doesn't matter how much substrate is in the system, it's only going to be metabolized and eliminated at that maximum velocity. You can't change the velocity because it's zero order. Number 2, do most drugs exhibit first order kinetics or zero order kinetics in their metabolism and elimination? Most drugs are eliminated and metabolized by first order kinetics. This means the rate of elimination is directly proportional to the plasma concentration. Number 3, in which order of elimination is the plot of drug concentration versus time linear? This is zero order elimination. Here there's a constant amount of drug that is eliminated per unit of time, regardless of how much drug is in the system. Number 4, what drugs demonstrate zero order kinetics in their metabolism? Your mnemonic here for like a zero, which is a P shape, is PEA for phenytoin, ethanol, and aspirin. Those are 3 drugs that you should know have zero order kinetics. Again, there's a constant amount of drug elimination per unit of time. Regardless of how much drug is in the system, you can only eliminate so much. Number 5, which phase of biotransformation is performed by cytochrome P450? So we've talked about phase 1 and phase 2. Cytochrome P450 is involved with phase 1 metabolism. Number 6, what is the most common and most important phase 2 conjugation reaction? This is glucuronidation. Here, glucuronic acid is added to the drug. This results in drug inactivation and also facilitates drug excretion by making the molecule more polar. So that's it for this quick review. Let's get back to your main lecturer.
We've got the drug administered into the system, we've got it absorbed from the GI tract, we've got it distributed throughout the system, and we've got it metabolized. So now we need to get it completely eliminated from the body. So we're going to talk about drug elimination. Now there are numerous routes of drug elimination, but the most important one is renal elimination, or through the kidneys. Drugs are excreted in the urine very often. Some drugs can be removed through hemodialysis, which is where you take the blood out of the body and run it through a dialysis filter and remove drugs and toxins and that sort of thing in patients who have kidney failure. Drugs are also eliminated through the bile. Some drugs are eliminated in the intestine. A small number of drugs are eliminated in the lungs and actually breathe out the toxic metabolites. And in nursing mothers, you can eliminate drugs through the milk. So let's focus on renal elimination because that's by far the most common site of drug elimination. We're going to look at the image there in the textbook of the nephron, and we're going to follow each part. We're going to follow the drug through each part of the nephron and see how elimination works at each of these sites. So beginning with glomerular filtration, the drug is delivered in the blood by the renal arteries, and it goes into the glomerular capillaries. And the free drug, that is the drug that's not bound to albumin, because remember, drugs that are bound to protein are stuck in the circulation. The free drug is going to flow through the slit junctions in the capillaries into Bowman space, and it's going to pass with this glomerular filtrate down in through the tubules. Any drug that didn't enter the glomerular filtrate is going to leave the glomerulus in the efferent arterioles and then go through another capillary bed that surrounds the proximal tubules. And here we need to talk about proximal tubular secretion. Drugs can be actively transported from these capillaries into the proximal tubules. Remember, active transport requires some energy. And there are a couple of different transporters. There's a transporter for cations and there's a transporter for anions. Very often a single transporter can transport many different drugs, and this can lead to competition. So if there's a lot of drugs, a lot of cation or anion that needs to be transported, they may compete for the binding sites and compete for the transporters. There's a drug called probenecid, which is a drug used to treat gout, and it can block tubular secretion of several drugs, including penicillin, naproxen, ketoprofen, and indomethacin. So if you give probenecid with penicillin, the penicillin is not going to be transported in the proximal tubule, and the drug level of penicillin is going to be generally higher. So sometimes we actually give probenecid to increase the plasma levels of penicillin because we're decreasing excretion of penicillin. And then we'll talk about reabsorption in the distal tubules. As the drugs that are in the glomerular filtrate are proceeding down through the loop of Henle and then to the distal tubule, the concentration of the drug increases because the kidneys are extracting water and concentrating the urine. So the concentration of that drug in the urine is increasing. And remember that charged drugs cannot pass through the lipid bilayer cell membrane very easily, but an uncharged drug, a lipophilic drug, can. And they may, as they concentrate in the distal tubule, they may actually be reabsorbed by passive diffusion. They're just passing through the cell membrane and back into the interstitium from high concentration to low concentration. They're going to get back into the systemic circulation. So how do we prevent this from happening? Well, we can manipulate the pH of the urine in order to prevent this. So I'm going to take a little sidetrack now and talk about acids and bases. And we touched on this earlier in the Pharmacokinetics Part 1 lecture. Remember, we said that pH will influence how much of a drug is charged or uncharged. The value you need to remember for this is called the pKa. The pKa is the acid dissociation constant. And every individual drug has its own individual pKa value. So the pKa is defined as the pH at which the non-protonated form of the drug is equal to the protonated form of the drug. So every drug will exist in both a protonated and a non-protonated form, and the relative amounts of those two is determined by the pH of the surrounding environment. And so the pH at which the protonated form is equal to non-protonated form is defined as the pKa, or acid dissociation constant. So we're talking about renal drug elimination. So we're talking about the pH of the urine as the environment. So if the pH of the urine is lower than the pKa, then the protonated form of the drug is going to be predominant. And for acids, the protonated version is HA. If you have a basic drug, the protonated form is still predominating, and the protonated form of the basic drug is BH+. And if you have an alkaline urine, a basic urine, that means that the pH is higher than the drug's pKa, and so the non-protonated form of the drug will predominate. And again, for acidic drugs, the non-protonated form is A-, and for a basic drug, the non-protonated form of the drug is B. And then also you have the protons, the H+ out there as well. So in the alkaline urine, in the basic urine, if you have an acidic drug, you have the proton H+ and the drug A-. And if you have a basic drug in an alkaline urine, you have the proton H+ and the uncharged base B. So the pKa tells you which form of the drug will predominate, and it will also tell you how easily that drug will diffuse across the membrane. So if you have an uncharged drug, that drug can cross the lipid membrane very easily. It will be rapidly absorbed from the urine. If you have a charged drug, remember, charged ions cannot cross that lipid bilayer membrane very easily, and so those charged drugs will be trapped in the urine. So if a drug is a weak acid and the urine is acidic, which means the pH is lower than the pKa, then which form of the drug is going to predominate? Well, it's the protonated form of the drug. So the protonated form of the acid is HA, and that's an uncharged drug, so it's able to be reabsorbed and diffuse across the cell membrane. And all that drug is going to be reabsorbed in the kidney's distal tubules. Now, if you have the same drug that's in an alkaline urine, and so the pH is now greater than the pKa, which form of the drug is going to predominate? Well, it's the non-protonated form of the drug, and the non-protonated form of that acidic drug is A-. So that A- anion is trapped in the urine, and it will be excreted rapidly. So if you're trying to enhance excretion of an acidic drug, say you've got an overdose of a drug that happens to be an acid, and you want to get rid of that drug more rapidly, what can you do? Well, you give sodium bicarbonate, and that's going to make the urine alkaline or basic. And that's going to facilitate elimination of the drug. Because as we said, a weak acid is going to be trapped in the urine if that urine is alkaline or basic. So there are two important clinical scenarios that utilize this. One is if you have an overdose of aspirin. And remember, aspirin is acetylsalicylic acid. It's an acid drug. So if you have an overdose of aspirin, you want to give that patient sodium bicarbonate in order to alkalinize the urine, and that's going to facilitate excretion of the aspirin. Another situation is an overdose of tricyclic antidepressants. These are old antidepressant drugs that are also weak acids, and patients sometimes will try to commit suicide by overdosing on these, and they can be very toxic. So again, you alkalinize the urine, and that will facilitate elimination of the drug. If, on the other hand, the drug is a weak base, you can acidify the urine in order to facilitate clearance. So a couple of examples of weak bases include cocaine and amphetamines. So if you acidify the urine with ammonium chloride, you're going to cause the drug to be in the protonated form, and the protonated form of the base is the BH that's positive, and it's that cation. And so you're going to concentrate that cation in the acidic urine. So now that we've talked about the acid-base situation, let's talk about the quantitative aspects of renal drug elimination. So drug clearance, or CL, is expressed as the volume of plasma from which all the drug is removed in a given time. It might be milliliters per minute, or it could be liters per hour, or gallons per year, or whatever, but it's a volume per time. Pay attention to the units when you're working these problems, because you can get really tripped up in the calculations if you don't. Clearance also equals renal plasma flow multiplied by something we call extraction ratio. And this is going to be variable from person to person, but it's fairly constant over time in a single person. So I may not have the same clearance that you do, but drug clearance for me for a specific drug should be about the same all the time, assuming no major changes in my health. So we mentioned extraction ratio. This is a ratio between the drug concentration in the renal vein and in the renal artery. So if you were able to go in and sample the renal vein and get a drug concentration, and then sample the renal artery and get a drug concentration, you could see how much drug was cleared by the kidney, and you could, you could determine what percentage of the drug was cleared on a single pass. Is it 25%? Is it 60%? But really, this isn't something you can measure. We don't go around and do renal artery sampling on any patients ever, really. So another concept is the excretion rate, and this is found on page 18. The excretion rate is the clearance times the plasma concentration. The excretion rate is milligrams per minute. Clearance is milliliters per minute, as we said, and plasma concentration is milligrams per milliliter. So the clearance is volume per time. It's how much plasma is cleared of drug in a certain amount of time. Excretion rate is a mass of drug per time. It's an amount of drug, not a volume of plasma. The excretion rate is how much drug is excreted in a given amount of time. So if you do a little algebra on this excretion rate formula, you get clearance equals excretion rate divided by the plasma concentration. Now, I mentioned that there are 4 important equations that you need to know to pass your boards. None of these equations that we just talked about is one of the 4. But the next equation we're going to talk about is. That's the equation for half-life. Half-life is a very important concept. Half-life is the amount of time it takes to reduce the amount of drug in the body by 1/2. So half-life is a time. It's the number of minutes or number of hours or sometimes days. Now, really this only works for first-order kinetics. Remember that drug elimination is first order for most drugs, so you have a certain percentage of the drug that's eliminated in a certain amount of time. The absolute amount of drug that's excreted is going to depend on the concentration. So the important equation here is clearance equals 0.7 times the volume of distribution divided by T1/2. And T1/2 is your half-life. Sometimes instead of 0.7, you'll see 0.693. The real factor is negative natural log of 0.5, which is something like 0.693 something something. 0.7 is close enough. It'll get you close enough for your calculations. You can also express this same formula as clearance equals volume of distribution times Ke. Ke is an elimination constant. And Ke, if you look at that formula, is obviously 0.7 divided by the half-life. But that's not the equation you need to memorize. The equation you need to memorize is clearance equals 0.7 times volume of distribution divided by the half-life. So for a problem, you might be given the volume of distribution and a half-life and be asked to calculate the clearance. Or you might be given an IV dose and a plasma concentration, so you can calculate the volume of distribution, because that's one of those important equations to know. And then when you have the half-life, you can also calculate the clearance, or you can do any combination of these. But this is a common board question. You need to know this formula. Next, we'll talk about the total body clearance. So I'm talking about these drugs as if they're completely eliminated by the kidney, and some drugs are. But for most drugs, you're going to have a little bit of excretion by the liver and a little bit of excretion here and a little bit of excretion there. And the total body clearance is really the sum of all these clearances, the sum of the renal clearance plus the sum of the hepatic clearance and the sum of the pulmonary clearance and so forth. So clinically, the concept of half-life is more important than the calculation involving it. Because half-life is dependent on patient factors that you can't really measure. So you need to understand what the half-life is. You need to have that concept cemented in your head, but you're not going to do a lot of calculations with half-life, because really when you look up a half-life in a drug table or a drug book or something, you're going to see the range of time. It's going to say the half-life is 2 to 4 hours or 12 to 24 hours or something like that. It's not going to give you a specific half-life, because that's patient dependent. There are a lot of different clinical situations that affect half-life. If you have increased half-life or slower clearance of a drug, that might be from diminished blood flow to the kidneys or liver. It might be from decreased extraction ratio, such as from renal disease, where you're not able to extract as much of the drug. It might be because of liver disease, where you have decreased metabolism. Because remember, if you can't perform those biotransformation reactions on the drug, the kidneys can't hold on to those hydrophilic drugs. So liver disease or kidney disease or diminished blood flow can all increase the half-life and slow the clearance of the drug. Then there are some conditions that can cause a decreased half-life or faster clearance of the drug. These include increased hepatic blood flow or more metabolism, decreased protein binding. Remember, only the free drug is filtered in the glomeruli, so if the drug is bound to more protein for whatever reason, that's going to decrease the half-life. And then also increased metabolism. So if you have induction of the P450 system, you're going to have more metabolism of the drug, and that may decrease the half-life of the drug.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. All right, let's go through the answers to quick review number 2. Number 1, what effect does probenecid have on secretion of drugs in the proximal tubules? So probenecid blocks tubular secretion of several drugs. This includes penicillin, naproxen, ketoprofen, indomethacin. And the result of this blocking of tubular secretion is to reduce the elimination and prolonging the duration of time that the drug is in the system. So the drug is going to have a longer half-life because you're not getting rid of it as readily. So in previous world wars where there may have been a shortage of penicillin, probenecid was used in that situation to conserve penicillin by reducing the frequency and amount of dosing. Number 2, which form of a weak acid will predominate when the urine is alkaline, or more specifically, when the urine pH is greater than the drug's acid dissociation constant, or pKa? This is the non-protonated form. Number 3, why is giving sodium bicarbonate useful in the treatment of some overdose situations? Sodium bicarbonate is going to alkalinize the urine, which is going to trap the acidic drugs such as aspirin and tricyclic antidepressants. Number 4, your patient is on drug X, which has a volume of distribution of 50 liters in this particular patient. Different sized patients have different volumes of distributions, and different drugs are going to distribute in different compartments, whether they're more charged, whether they're bound to albumin, whether they're more polar, and so forth. This particular drug in this particular patient has a volume of distribution of 50 liters. The patient clears this drug from plasma at a rate of 10 liters per hour. What's the half-life? So you use your equation for clearance, which is 0.7 times the volume of distribution divided by the half-life. You rearrange the equation to calculate your half-life. So you get the equation 0.7 times the volume of distribution divided by your clearance. The volume of distribution is 50, multiply that times 0.7, divide that by 10, you get 3.5 hours. Number 5, what single factor determines the length of time required to achieve steady state? This is the drug's half-life. Number 6, how many half-lives does it take to clear the following amounts of drug for the body? So half-life, it just makes sense. It's the amount of time that it takes to clear 1/2 of the drug from your body. So if you want to clear 50% of the drug, that's 1 half-life. You're left with 50%. So what's 50% of that 50%? It's 25%. So you're going to have 75% cleared, 25% remaining after 2 half-lives. And then you have 87.5% is cleared after 3 half-lives, and then 94% is cleared after 4 half-lives. So these half-lives relate to drug metabolism and elimination. They also relate to infusing a drug to reach a steady-state plasma concentration. So if you're not giving a loading dose of a drug, but you're administering a drug by constant infusion, it's going to take 4 half-lives to get up to 94% concentration. And if you stop the infusion, it's going to take 4 half-lives to get rid of 94% of that drug from your body. Number 7, how does a half-life of a drug translate to a dosing interval? And, when we dose drugs, we don't really talk about half-life so much. We talk about the frequency of dosing. You're going to take this medication 3 times a day, or 2 times a day, or every 8 hours. The dosing interval is usually 2 half-lives, which means that most medications with a half-life of 12 hours are going to be dosed every 24 hours. So most 24-hour medications have a half-life of 12 hours. And most medications with a half-life of 6 hours are dosed twice a day, because usually the dosing interval is 2 half-lives. So that's it for this quick review. Let's get back to your main lecturer.
So now we're going to put this all together and talk about how this works in real-world situations. We're going to talk about kinetics of continuous administration, where we're giving these drugs through a continuous IV infusion, or we're giving fixed dose, fixed time interval dosing, such as 100 milligrams every 6 hours or something like that. For right now, we're going to assume that the drug is distributing into just one compartment. It's a little simplistic, but it makes the concepts much easier to understand. So let's talk about kinetics of IV infusion. The rate of drug entry is constant. You're giving a constant amount of drug all the time in an IV infusion. And elimination is usually first order, which means that elimination is proportional to plasma concentration. You're going to eliminate a certain percentage of the plasma concentration all the time. So if the plasma concentration is higher, you're going to eliminate more milligrams of the drug. And we need to talk about steady state levels in a continuous IV infusion. When you have continuous IV infusion, the plasma concentration is going to go up and up and up until eventually the elimination rate matches the input rate. So your body's going to be eliminating more and more and more of the drug until you're eliminating exactly as much as you're putting in, assuming you're not giving some insanely high dose that just overwhelms the body's ability to eliminate and excrete the drug. So the patient is going to achieve a steady state where drug in equals drug out, and the plasma concentration is going to be constant at that steady state. So we have 2 questions to answer. Number 1, how does the infusion rate affect that steady state concentration? And number 2, how long does it take to achieve that steady state? So our first question, how does infusion rate affect the steady state concentration? Toward the bottom of page 19 you see this formula. And again, this is not one of the formulas you need to memorize, but it helps you see a couple of things. So you see the formula CSS equals R over KE times volume of distribution. So CSS is the plasma concentration at steady state. R is the infusion rate. And we've already seen that the denominator, KE times volume of distribution, is clearance. We saw that when we were talking about half-life. Look back and you'll see that. So plasma concentration at steady state equals R, or the infusion rate, divided by clearance. This helps us see 2 things that are kind of obvious, but they're pretty important, so I want to point them out, just so you can get the concept. First of all, it helps you see that the steady state plasma concentration is directly proportional to infusion rate. So the elimination constant and volume of distribution and clearance can all vary from patient to patient. Mine might not be the same as yours, but for me it's always going to be the same over time for a specific drug. So the plasma concentration at steady state is directly proportional to the infusion rate. The more drug you give per hour, the higher that plasma concentration is going to be at steady state. So in clinical practice, when you give a a drug through an IV infusion, you got a bag of drug and you've got an IV tube connected to it, and you hang it on a IV pole and you run that tubing through an infusion pump, and then the IV goes into the patient's arm. And the infusion pump, you can program it to give 50 milligrams per hour or 100 milligrams per hour or 200 milligrams per hour. And as you increase that rate, that infusion rate, you're going to increase the ultimate plasma concentration once you reach steady state. The steady state plasma concentration is also inversely proportional to the clearance. So anything that decreases clearance is going to increase the concentration at steady state. That's pretty obvious. Also, anything that increases clearance, such as increased metabolism, is going to decrease the steady state concentration. So it's pretty obvious stuff, but it's important concepts. You need to pay attention to that. The other question that we're going to ask is, how long does it take to achieve steady state? At 1 half-life, you're going to be half of the steady state concentration, which is half CSS. At 2 half-lives, you'll be at 75% of the steady state concentration. At 3.3 half-lives, which you see there, you're going to be at about 90% of the steady state concentration. So if the half-life is 12 hours, how long does it take to get to 90% of the steady state concentration? Well, 12 hours times 3.3 is 39.6, or about 40 hours. For convenience sake, you can say that you'll achieve steady state concentration after 4 or 5 half-lives. Lippincott says 4 half-lives. I always learned 5 half-lives. 4 half-lives means you're going to achieve 93.75% steady state concentration, and 5 half-lives is 96.875% of steady state concentration. So, it's pretty close. Somewhere around 4 or 5 half-lives, you're going to get pretty close to the steady state concentration. So how do we use this concept practically? Well, if you start a drug infusion at 100 milligrams per hour, and you know you're going to have to draw blood eventually in order to adjust the rate to achieve your target blood level, when should you draw the blood? Well, you look up the half-life of the drug, and remember, this is sometimes going to say 4 to 6 hours or 10 to 12 hours. It's going to give you some range. But you can estimate what that is and check the blood level after 4 or 5 half-lives. Once you've been on the infusion for 4 or 5 half-lives, you should be at your steady state concentration, or pretty close to it. If you check the blood level too soon, you haven't gotten to steady state yet, and you start adjusting based on those drug levels, you're going to adjust improperly, and you're going to wind up with too high a level or too low a level. So the only 2 things that affect how long it takes to reach steady state concentration are the half-life and the elimination constant, which we saw was inversely proportional to the half-life. So changing to a higher rate of infusion is not going to get you to steady state concentration any faster. Remember, steady state is not a concentration, it's a state in which the drug is being eliminated at the same rate as it's going in. So if your goal is to get your patient to a plasma level, a certain plasma level, you can give a faster infusion to get to that level, but you're not going to be at steady state. When you increase the rate of infusion, you're just increasing the concentration at steady state. You'll get the drug in faster when you increase the infusion rate, but with first-order kinetics, more concentration means more elimination. So you're eliminating the drug faster as well. By definition, steady state is when the infusion rate equals the elimination rate. And so you're not going to get there any faster. The only thing that determines how fast you get to steady state is half-life. So we're going to go out of order for a minute and talk about loading dose and maintenance dose. So sometimes you can't wait 4 or 5 half-lives to get a patient to a desired drug level. They might get sicker, they might die while you're waiting, this 4 or 5 half-lives. So instead of just waiting, we give a loading dose. We give a higher dose in order to get the drug level up into the therapeutic range. And then you start the infusion to maintain the steady state. That maintenance level is called a maintenance dose. So we have a loading dose and a maintenance dose. And these are the last 2 equations you really need to know, you really need to have memorized for your Step 1 boards. The 2 equations are loading dose, or LD, is equal to concentration at steady state times the volume of distribution. And The maintenance dose, or MD, is equal to concentration at steady state times clearance. Now, these equations are important. You need to know them. They only work, though, for IV drugs. If you're going to use them for oral drugs, you have to assume 100% bioavailability. If a drug only had 75% bioavailability, the amount of drug you're giving isn't all getting into the circulation. Only 75% of it is, so you'd have to account for that. And you can see in Lippincott the way to do that. The loading dose equals concentration at steady state times volume of distribution divided by F, where F is the bioavailability, or the maintenance dose equals concentration at steady state times clearance divided by F, where F is the bioavailability. The good news is we've never heard of a board question where they asked you to account for bioavailability. They'll either tell you this is an oral drug with 100% bioavailability, or more commonly they'll say this is an IV drug in which all the drug given is immediately bioavailable. So you see here all four of the equations that you need to memorize. It's important that you know these in order to pass Step 1. These are definitely high yield for Step 1 of the USMLE and Level 1 COMLEX exams. Next, we're going to talk about washout kinetics. So when you stop infusing the drug, you've achieved steady state and then you turn off the infusion, you have the same first order exponential decline in drug levels that's determined by half-life. It's just like the ramp up phase, only it's inverted. So at 1 half-life, you've eliminated half the drug. At 2 half-lives, you've eliminated 75% of the drug. That's half of the 50% that was left after the first half-life, so half of that's 25, so 50 plus 25 is 75%. At 3.3 half-lives, how much have you eliminated? 90%. Just like at 3.3 half-lives during a constant infusion, you've gotten up to 90% of that steady-state plasma concentration. At 3.3 half-lives, after you stop the infusion, the drug level has declined by 90%. And just like it took 4 to 5 half-lives to get up to steady-state plasma concentration, it's going to take 4 to 5 half-lives to completely eliminate the drug. And remember, infusion rate didn't really affect how long it took to get to the steady state, so the starting concentration doesn't really affect how long it takes to clear the drug. The only thing that determines this is the half-life. It doesn't matter if you have 100 milligrams to start with in the your plasma concentration is 100 milligrams per liter, or it's 50 milligrams per liter. It's going to take 4 to 5 half-lives to clear each of those because the amount that is cleared is proportional to the drug level. It's a constant proportion that's cleared, not a constant amount. So we're almost to the end. Hang in there for one more little topic, and that is the kinetics of fixed dose and fixed time interval regimens. So even in a hospital, when you've got a patient getting IV drugs, it's a lot simpler to give a certain amount of drug, a certain fixed dose at a certain interval. You might give 100 milligrams every 4 hours or something like that. And obviously, this is how oral drugs work. So if you give a single IV injection, the dose that you've given doesn't really affect how long it takes to clear the drug. Remember, we said only the half-life determines how long it takes to clear the drug. So if you're giving multiple IV injections, we're assuming that you're going to give the drug more frequently than 5 half-lives. So at the time of the second dose, there's still a little bit of that first dose that's left in the blood. And so the plasma concentration after the second dose will be a little higher than it was after the first dose. And then after the next dose, there's still a little bit of drug left, so it's going to be a little higher, and it's going to continue increasing. The peak value is going to continue increasing in a stepwise fashion until you get to that steady state concentration. And once you get to steady state, the drug elimination is equal to the drug administration. You can give smaller doses at shorter intervals, so maybe every 4 to 6 hours instead of every 24 hours, but it won't affect the steady state concentration or how long it takes to get there. Remember, what influences or what determines steady state concentration? Just the dose given, how many milligrams. And what determines how long it takes to get to steady state? Just the half-life. So giving a smaller dose at a shorter interval isn't going to affect the steady state concentration. If you're giving the same daily dose, if you're giving 200 milligrams divided 3 times a day or 4 times a day, 50 milligrams 4 times a day, it's going to give you the same steady state concentration as if you were giving all 200 milligrams once a day. So let's talk about how this works with oral drugs. With IV drugs, you don't really have to worry about absorption. When you give an IV drug, it's all absorbed into the circulation more or less instantaneously. But with an oral drug, there's a delay as the drug is absorbed. You have a single dose curve, so you have a delayed onset as the drug is gradually absorbed, and then it reaches a maximum concentration, and then you see the washout is basically that same first order kinetics curve.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. Let's go through the answers to quick review number 3. Number 1, you need to start your patient on continuous IV infusion of drug Y, which has a volume and distribution of 10 liters in this particular patient. What is the loading dose required to achieve a plasma concentration of 5 milligrams per liter? So in order to achieve this calculation, you need to know the equation, one of the 4 important pharmacokinetic equations. This particular one is loading dose is equal to concentration at steady state times the volume of distribution. And in this equation, the concentration at steady state represents the target concentration or the desired concentration. So in this case, we're trying to achieve a concentration of 5 milligrams per liter, so that's your concentration at steady state. Multiply that times the volume of distribution, and you get 50 milligrams would be your loading dose. Number 2, you eventually have the same patient on a maintenance dose of 60 milligrams per hour of drug Y, which achieves your desired plasma concentration of 5 milligrams per liter. What is the clearance of drug Y in this patient? So you need the equation of maintenance dose is equal to concentration at steady state times your clearance. You can rearrange that equation for clearance is equal to maintenance dose divided by the concentration at steady state. So your maintenance dose here is 60 milligrams per hour. Your concentration at steady state, or your plasma concentration is 5 milligrams per liter. So you divide that, you get 12 liters per hour is the clearance here. Number 3, a diabetic patient, this is a very common scenario, a diabetic patient on gentamicin for Pseudomonas sepsis receives a CT scan of the chest with IV contrast to rule out a pulmonary embolism. So it's a very common protocol to rule out a pulmonary embolism. 12 hours after the test, it is discovered that the patient's serum creatinine level is 3 times higher than normal, indicating the patient presumably has contrast-induced nephropathy. So you have a diabetic who is more likely to have kidney disease, a patient on gentamicin, which can be nephrotoxic, and you've given them IV contrast. That combination is not always problematic. In this particular case, it is. And so the creatinine level is going up, indicating some renal problems, some renal insufficiency. If the patient continues on gentamicin and needs to be started on vancomycin for a new suspicion of MRSA, how does the loading dose of vancomycin and the maintenance dose of gentamicin need to be changed because of the new nephropathy? So this patient's clearance has been reduced, not clearing the drug as well. So do we need to do anything to the vancomycin loading dose? Do we need to do anything to the gentamicin maintenance dose? So because both of these medications are renally excreted in renal failure patients, you need to alter the dose of these medications. So the loading dose, let's talk about that first. So loading dose, we said the equation is concentration at steady state times the volume of distribution. Does loading dose have anything to do with clearance? No, it doesn't. So the loading dose of vancomycin is going to be no different than it would be for any other patient. Only if the patient was larger would you increase the loading dose, because the volume of distribution for a large patient is a lot larger than it is for a smaller patient. So the main variable for changing the loading dose is how big the patient is. Maintenance dose, we said, was equal to the concentration at steady state times clearance. So the maintenance dose of gentamicin in this patient would need to change because the clearance has changed. The clearance has been reduced, so you're going to need to reduce the dose of gentamicin. So the common gentamicin dosing interval is about every 8 hours. In renal patients, you dose gentamicin maybe every 12 hours, maybe every 24 hours, maybe every 48 hours, depending on how severe the renal disease is. Number 4, a medication with a half-life of 6 hours is dosed by continuous IV infusion. How many hours will it take for this drug to reach 94% of its final steady state level? We have a half-life of 6 hours, and we know that after 4 half-lives, you get to 94%. It's an important number to know. 4 half-lives, 94%. So in this particular medication, it's going to take 24 hours, because 6 times 4 is 24 hours. Number 5, Two patients are each given IV injections of drug Z with a half-life of 10 hours. Patient A receives a single dose of 100 milligrams. Patient B receives a 1,000 milligram dose, so 10 times the dose of the first patient. For each patient, calculate the amount of time required to clear 94% of the drug, assuming first-order kinetics. So the amount of time that would take to clear this drug in patient A is 10 hours, because the half-life is 10 hours for one to get 50% cleared. But we're talking about 94%, so it's going to be 4 times that. So it's going to take 40 hours for patient A to clear their medication. How about patient B? How long does it take this patient, to clear 94%? Also, same drug, same half-life, 40 hours, right? So this is kind of a trick question. The time required to clear the drug depends only on the half-life, is independent of the starting concentration. Now, of the 6%, you've cleared 94%. Of the 6% that remains in patient A and the 6% that remains in patient B, you're going to have 6% of 10 milligrams versus 6% of 1,000 milligrams. So you're going to have more total drug still in patient B, but that's not the question that you were asked. You were asked about the 94%. So the percentage is not going to change, although the total amount of drug might be different. Number 6. The patient comes to the hospital with a dose of 100 milligrams of extended-release metoprolol and is admitted for chest pain. Since your hospital formulary does not have extended-release metoprolol, you have to place the patient on twice-daily metoprolol instead during his stay. On what dose of twice-daily metoprolol do you give this patient? This is a very common scenario, and this is a very common mistake that a lot of new interns make, and so I don't want you guys to make this mistake. You might be tempted to say, 100 milligrams of extended-release medication, you're going to give it twice a day now, and so that would be 50 milligrams twice a day. That would be true if you stuck with the extended-release formulation. So 100 milligrams of extended-release once a day is the same of 50 milligrams twice a day of extended-release medication. But you're not using extended-release medication anymore. You're using now a medication that has a half-life that's half of what the previous medication was. So what dose of regular old metoprolol do you need to use? It's 100 milligrams twice a day. And let's think about this. If of the extended-release medication, you start a patient on 100 milligrams, how much is going to be left, assuming 100% bioavailability, how much is going to be left in the system after 12 hours? Assuming a half-life of 12 hours, the amount that's going to be left is about 50 milligrams, and after 24 hours, you're going to have 25 milligrams left, right? Well, in a patient that is taking a regular old metoprolol that has half of that half-life, a half-life of 6 hours, then they take a dose of regular metoprolol of 100 milligrams. 6 hours later, they have 50 milligrams, and then 6 hours after that, they have 25 milligrams. So you're redosing it with another 100 milligram dose. So the average is what's important here. So again, just to reiterate, on this particular patient, you would give them, if you're switching them from 100 milligrams of extended-release metoprolol once a day, and you want to give them metoprolol that has to be dosed twice a day that's not extended-release, that is going to be 100 milligrams twice a day that you give. Number 7, an inpatient is on 100 milligrams of twice-daily metoprolol, and you need to increase the dose by 50%. Your hospital formulary, for whatever reason, only carries 100 milligram tablets of metoprolol. What are 2 options for increasing the dose in this patient by 50%? Option number 1 is these tablets you can cut, and so you can have the hospital pharmacy cut the tablets, and you can split one of those 100 milligram tablets and then dose 150 milligrams twice a day to the patient. Alternatively, you could continue using the 100 milligram tablets, but increase the dosing frequency by Q8 hours to Q8 hours. So a patient, instead of having twice a day, now they're getting 3 times a day dosing of metoprolol. And then just one last little thing I'd like to mention. There is a difference between BID, or twice a day dosing, and Q12-hour dosing. So BID dosing is commonly dosed during waking hours. You're going to take it twice a day during waking hours. And it is very often the case that twice a day dose is given at 12-hour intervals. You have a patient taking something at 7 a.m. on BID dosing. Ideally, they would take the next dose at 7 p.m. But sometimes our patients will say, oh, twice a day, I'm going to take one in the morning when I wake up, maybe that's 8 or 9, and then I'm going to take it in the evening after my dinner about 5 o'clock. So you can see that's twice a day dosing. And if you're in the hospital and you write for twice a day, that's what they're going to get. They're going to get a dose with breakfast and a dose with dinner. If you're in the hospital and you write for Q12-hour dosing, Q12 hours means 7 a.m., 7 p.m., exactly 12 hours. In the same way, if you write TID dosing, or 3 times a day dosing, they're going to get a dose with breakfast, a dose with lunch, and a dose with dinner. So it's 3 times a day during waking hours. If you're in a hospital and you write for Q8-hour dosing, they're going to get a dose every 8 hours, even if that dose happens to fall at 2 a.m. You wrote Q8 hours, they're going to get it every 8 hours. So just a little subtle distinction to be aware of. Okay, so now's a good time to pause the video and complete your in-session quiz, then restart the video and we'll go through the quiz together.
Welcome to Stepping Up with me, Richard Sammons. Woo! Woo! Step up, you. Hop, 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 hop like you mean it. This year, I'm your Easter Bunny with a yummy chocolate egg of wisdom for you. What drugs are famous for inhibiting cytochrome P450? Here's a quick way to remember. P-I-C-K-E-G-S. Pick eggs. Protease inhibitors. Isoniazid. Cimetidine. Ketoconazole. Erythromycin. Grapefruit juice. Sulfonamides. Got it? Protease inhibitors. Isoniazid. Cimetidine.
Hi, I'm Dr. Chris Lewis. I'm one of the DIT Chief Educators. Today we're doing the in-session quiz for drug metabolism and elimination. Let's get started. Which organ is the most important site of drug metabolism? Well, that's going to be the liver. List 3 drugs that demonstrate zero-order kinetics in their metabolism. Well, that's going to include phenytoin, ethanol, and aspirin. And you can remember this by the mnemonic P, P-E-A, and it looks like a 0, so that's zero-order kinetics. Which form of a weak base will predominate when the urine is alkaline, meaning the urine pH is greater than the drug's acid dissociation constant, or pKa? Well, the answer is the non-protonated form. Explain how CYP enzyme induction can increase the activity of some drugs and decrease the activity of others. Induction of the cytochrome P450 will increase drug metabolism, but some metabolites of some drugs are more active than the parent compound, while metabolites of other drugs are less active than the parent compound. What are the 4 high-yield equations that are most important to know for USMLE Step 1? Well, first is volume of distribution, which is equal to the amount of drug in the body divided by the plasma concentration of that drug. The next is clearance. So clearance is equal to 0.7 times the volume of distribution divided by the half-life. Next is the loading dose. So the loading dose is equal to the plasma concentration at steady state times the volume of distribution. And finally, maintenance dose. Maintenance dose is going to equal the plasma concentration at steady state times the clearance. If 50 milligrams of drug X is administered and the plasma concentration is 2 milligrams per liter, first, determine the volume of distribution. Well, the volume of distribution is going to equal the amount of drug in the body divided by the plasma concentration of that drug. So 50 milligrams divided by 2 milligrams per liter is going to equal 25 liters. Next, if the clearance of drug X is 3.5 liters per hour, what is the half-life of drug X? Well, we're going to have to do a clearance. So the clearance equals 0.7 times volume of distribution divided by the half-life. So by doing a little bit of algebra there, you end up with the half-life equaling 0.7 times 25 liters divided by 3.5 liters per hour. So the half-life is going to be 5 hours. If you want to reach a steady state of 3 milligrams per liter, determine what the loading dose should be. Well, the loading dose is going to equal the plasma concentration at steady state times the volume of distribution. So you're going to plug in your numbers. 3 milligrams per liter times 25 liters is going to equal 75 milligrams. What is the difference between first order and zero order kinetics? In first order kinetics, a fraction of the drug is metabolized or eliminated. In zero order kinetics, a constant amount of drug is metabolized or eliminated. Why must lipophilic drugs undergo phase 1 and 2 metabolism to be excreted by the kidney? Phase 1 and 2 metabolizes nonpolar or lipophilic drugs into polar drugs, meaning water-soluble drugs, which allows for renal excretion to occur. Levothyroxine, the treatment for hypothyroidism, has a half-life of 9 to 10 days when a patient is in a hypothyroid state. How long will it take to arrive at 90% of its steady state concentration? Well, the answer is about 30 to 33 days. So how did we get to that? Well, for 9 to 10 days times 3.3 half-lives, which is the number of half-lives to reach 90% of steady state. About how many half-lives does it take for a drug to reach its steady state concentration? Well, the answer to that is about 4 to 5 half-lives. And that's your in-session quiz for drug metabolism and elimination. Thank you very much.